Welcome, everyone, and thank you for joining us today in our webinar on expanding inclusion, an intersectional lens on family planning and reproductive health services for people with disabilities, Indigenous peoples, and LGBTQI plus communities within Asia. My name is Grace Gayoso, and I am the Asia Region Knowledge Management Officer for the Knowledge Success Project, a USAID funded project, which is the only global project that has laser focus on knowledge management for family planning and reproductive health programs. And please do type in the chat box your name and your organization and where you are coming from so that we would know who are here right now in our webinar. So to get things started, as you're typing in your name, your organization, and your country, we invite you to answer this simple question that you can now see on your screen. Next slide, please. So the question is, does your organization intentionally include underserved populations like people with disabilities, Indigenous populations, or LGBTQI plus when creating or implementing your family planning and reproductive health programs and services? So you can answer, you can type your answers in the chat box. So what is your answer to this question? Does your organization intentionally include underserved populations when creating or implementing family planning or reproductive health programs and services? We would love to hear from you, and please do type in your answers in the chat box. All right. So please do type it in. Okay.
I believe
So while
the chat box might be disabled, Gaio.
let us see. Is it? Mm-hmm. Is it disabled? There. It is disabled. Emily, before we I
It's
think
okay
people
now.
are Oh, it's okay now. It's working now. All right. Sorry for that one. Okay. And thank you. Now you can type in the chat box. Thank you. Thank you for that one. All right. So here, many people coming in and typing in. Thank you very much. And yes, some of you said, yes, you do serve underserved population, and so many people coming in from different parts of Asia, from Nepal, hey, Georgia. All right. Hey, thank you. And sorry for that technical glitch there. All right. Oh, also people
lesson
coming
one
from
in
outside.
lesson one in how to be more inclusive during webinars.
Yes. All right. So thank you very much. Okay. So yes, most of you said yes to this question. Thank you. Thank you for knowing that. And while you are still continuing to type your answers in the chat box, next slide, please. I'll be showing you what will be our agenda for today. So today's webinar is exciting because we will be hearing from 3 organizations who will be sharing their experiences on working and sharing working with underserved and underrepresented populations within the Asian context. Of course, we will hear from Roots of Health on how they provide family planning and reproductive health services for the most rural, underserved communities in the island of Palawan in the Philippines. The Blind Youth Association Nepal will share what worked well as they respond to FP or RH needs of people with disabilities. And lastly, the Family Planning Association of India will share their experiences on delivering family planning and reproductive health services among LGBTQI plus communities. And as you can see there, we'll be having the Q&A at the end of all presentations. However, you are free to type your questions in the chat box anytime. Our chat box is now okay. You can type now, and we will be collating all the questions coming through the chat box, and we'll ask these questions to our speaker during the Q&A. And as you can see also in our agenda, we will just be, before you hear from the speakers, we will be talking a bit about what is this definition of the term intersectionality. Okay, so now everyone is, let's just look here at your answers in the chat box. Yes, almost all do include the disabled, works with underserved population, and many people coming from India, Nepal, Philippines, wow, even from Mozambique and US. Good day to all of you. And next slide, please. So just some quick introductions before we start. All right. Again, once again, my name is Grace Gayoso, and I'll be your moderator for today. Next slide, please. And I would like to introduce our presenters for today. You will be hearing from Mr. Marcos Swanepoel, Deputy Director from Roots of Health Philippines. Hi, Marcos. There you go. And of course, Mr. Ram Chandra Gaire, Founder and General Secretary of the Blind Youth Association Nepal. And we'll also be hearing from Dr. Kalpana Apte, Director General of the Family Planning Association of India. All right, thank you. Next slide, please. And I would like to thank in advance, of course, the people who are behind the scenes supporting our webinar for today to make sure that it runs smoothly, to Emily and Brittany and Cosette, who are all from the Johns Hopkins Center for Communications Programs. Next slide, please. So before we listen to our speakers, let us learn a bit about this word that we will be hearing most of the time in today's webinar, which is intersectionality. So what do we mean when we talk about intersectionality? So to give some insight into the history of the framework, the term intersectionality was originally coined by Kimberly Crenshaw, a legal scholar and civil rights advocate in 1989. Originally, Crenshaw created the framework to describe how feminist and anti racist theories and policies relative to that time were not inclusive of Black women's experiences because they faced discrimination that was individual to them. And then over time, people began to share how their own identities and experiences overlapped with the term. So now people discussed how disability status, race, sexual orientation, ethnicity, gender, citizenship, and socioeconomic status also were reflected within this framework. And today, as you can see on the screen, Crenshaw defines the term as a metaphor for understanding the ways that multiple forms of inequality or disadvantage sometimes compound themselves and create obstacles that are often not understood within conventional ways of thinking about anti racism, feminism, or other social justice advocacy structures that we have. Next slide, please. And when we think about intersectionality in the context of family planning and reproductive health, many people that are a part of these intersecting identities often experience barriers to sexual and reproductive health services. So these identities also can have an impact on how much agency one has when it comes to making decisions about family planning methods. So, something to think about is how do we lead more inclusively in our family planning programs? All right. So that's a bit of an overview about the term intersectionality. So as a start, we have again another question for you, and please do type in your answer in the chat box. As a program implementer, how have you responded to the FP or RH needs of those living in very rural areas? How did it go? So, what is your experience on this? You can type it in the chat box. And while you are typing your answers to that question, I'll be introducing our first speaker. Our first speaker is from Roots of Health. Roots of Health or Ugat ng Kalusugan in Filipino is a nonprofit organization focused on improving the health of women and girls in their communities in the island of Palawan in the Philippines. Through comprehensive sexuality education programming, clinical services, and health system strengthening, including health worker training, and support to government partners, it works to empower and support women, young people, and their communities. Roots of Health has been operating as the only reproductive health organization in Palawan for the last 11 years. Next slide, please. So if you want to know more about Roots of Health, you can see their website on the screen. So please do check them out. So to discuss more on providing inclusive services for Indigenous peoples and youth, let us welcome Roots of Health Deputy Director Marcos Swanepoel. Marcos?
Thank you very much, Gail. Hello, everyone. Thank you for attending this webinar today. As Gaio said, we do provide information and services to young people and Indigenous people. So what you're looking at in this first slide is our first clinic. Sorry, Gaio, I thought you were going to go through the slides. You're not going to go through those slides. Am I going to share?
There you
great,
go.
thank you.
Yes.
So yeah, what you're looking at here is an image of our first clinic. You can see there's a teenage mother playing with her baby in the foreground, and there's a student walking by to get a consultation. And if you're wondering why I'm describing the image, it's for the sight impaired participants that may be joining us today. So could you please go to the next slide? So I apologize for the slide. This will be the only text-heavy slide in my presentation. When I started working on this presentation, I knew how I wanted it to go. And as I worked on it a little bit more, I realized that I was wrong about that. The intersectionality of young people and Indigenous people and LGBTQI plus people and their challenges and potential solutions was just too complicated. And so I'm a visual person, so I decided to map it out. There's a great tool called Program Evaluation Tool and Evaluation Planning Tool. And if you get a chance, it's fantastic. Check it out. And as you can see, though, there are a lot of issues that are common to both groups, right? And luckily, though, some of the solutions are too. Next slide, please. So, because we focus on reproductive health, most of our services are to women. And when we began work here in Puerto Princesa and Palawan, we started in communities. These communities lacked access to information and services. A number of these were home to Indigenous families. In this picture, you can see one of our nurses explaining to a group of rural mothers how contraceptive pills work. And over the years, we've done a lot of outreach to these Indigenous communities, not just here in Puerto Princesa, but across the province. What we found was there were a lot of myths and misinformation around family planning. and other reproductive health topics as well. But once our nurses explained how things worked, these were dispelled, and women ended up accessing the services that they had previously not wanted due to that kind of misinformation. So the issue really here was kind of a lack of access. So while the solution for us was community outreach and then later training government health workers, it wasn't always cheap, but it was simple, and it was also easily identifiable. You could see the geographic isolation. You could see the issues. And what worked then was that women wanted the information and they wanted the services. Now, given the amount of misinformation in Palawan, it wasn't surprising that teen pregnancy was such a big issue. 1 in 4, sometimes 1 in 5 pregnancies were to teenagers, depending on the municipality. And something that we didn't notice at first, and maybe you didn't notice, maybe you did if you look at this photo, right? But something that became apparent over time was that it was only mothers attending these sessions, no single young woman. Next slide, please. And although marriage was, or still is, more accepted amongst Indigenous groups here in Palawan, many of the girls didn't actually want to get pregnant in their teens. So we started training community health workers, and we asked them to reach out to young women, so that they could get access to information and services, but nothing changed. So we started talking to the young women themselves. And here you can see some of these women. These are teenage mothers in an Indigenous population community. And we talked with them and tried to figure out what could potentially work. And what they told us was that they weren't attending the sessions because they felt like they would be judged, and they weren't talking to the community health workers because they felt like the community health workers knew their parents, and the community health workers would tell their parents, right? So these negative perceptions weren't something that we really had the power to change. But our solution was to train younger health workers in the community who had in fact been teen mothers themselves. And suddenly we had a whole lot of young women accessing family planning. And over time, the number of teenage pregnancies in the communities decreased. Next slide, please. When we're talking about barriers to young people in particular accessing reproductive health services, in our experience, the biggest issue has been provider discrimination. And services should be free of judgment. They should make clients feel better, but the reality is that they aren't. So for us, what we've done is we have hired nurses based on their beliefs and human rights, especially amongst minority groups. And you can see one of our nurses here using a Doppler on a pregnant woman in the community, so the woman can hear her baby's heartbeat for the first time. What do I mean by evidence on the slide? Well, there is often evidence of discrimination, right? And oftentimes it's in the data. So in our case with the discrimination against young people, the data showed it. There were high teenage pregnancy cases, and when we looked at the contraceptive data, there weren't very many young people accessing services. So what we did was we conducted assessments of government health centers and provided the results and the evidence to not only the health centers, but also to the city health managers. And this led to some very interesting and frank conversations about the practices in the health centers and some behavior change. The next step for us, though, is to advocate for the inclusion of an indicator tracking adolescent contraceptive use, because you can't change what you don't measure. Next slide, please. So speaking of measurement, Our research that we've done into teen mothers has revealed that there's this 18-month period from when a girl gets a boyfriend to when she gets pregnant, right? And what we've also found in talking to a lot of young women and girls is that teenage girls don't feel like they need to learn about contraception, family planning, because they're not going to have sex until they get married, and when they get married they're not going to need family planning because they want to have babies. And this lack of information means that less young people access services, right? So really it's an issue on both sides. So we once had our staff once provided HIV screening to a 15-year-old boy who was sexually active. He had multiple partners. He visited the clinic because he had an STI, and he'd contacted us online. And after our staff doing the usual process of explaining that no coconut water would not cure the STI, he eventually came into the clinic. He got a checkup. He was luckily HIV negative, but he had no idea about condoms, no idea about the HIV threat. And luckily he did get treatment, but honestly, he's in the minority. So when we opened a clinic catering to young people, we really focused on building the awareness of the services that were available through social media, flyers, business cards, radio ads, the works. But the most important thing that we found that really worked was word of mouth, because young people trust other young people more than they trust adults. And what we found was that over time, more and more young people accessed services. Next slide, please. Another barrier that we found amongst young people was embarrassment. So a college student once told us about the story where she was trying to buy condoms, and when she got to the counter, the person at the counter would say, pretending that she didn't know how much they were, and kind of looking back through the store and raising her voice, saying, "How much are the condoms?" And as you can imagine, the student was totally embarrassed, and that put her off buying condoms for life. And this embarrassment is especially problematic, in this case and many other cases, because for young people, condoms are kind of their go-to form of contraception, right? So they should be easily available, but they're not. And young people are often just too embarrassed to get them. So our workaround that we found has been to try and make them more accessible. So we have youth volunteers who distribute condoms amongst their networks. We set up condom dispensers around the city. They get filled up. The youth advocates also distribute them to the kind of motels that you rent by the hour. And they go to events where young people are frequenting. So you can see here, here's one of our youth advocates at a large outdoor party, encouraging young people who are engaging in risky behavior to be less risky when it comes to sex. Last year, we distributed around 50,000 condoms. Next slide, please. Something that ties into embarrassment and family fear is this lack of confidentiality. And you can see how all of these kind of issues are related. And one of the reasons we actually opened a clinic for young people was that we noticed in our first clinic that when girls came in wearing a school uniform or university uniform, yeah, they wear those here, a lot of the women kind of would be giving them these judgmental looks, sometimes making some kind of under the breath comments. And yeah, we noticed that. And we noticed that the young women were really uncomfortable about that, right? This photo was taken in our youth clinic. There's a nurse talking to 3 high school girls about how contraception works. In both of our clinics now, there are private counseling areas, and something that has also worked has been utilizing appointments that clients can make through social media. They can use text. And initially, we set these up to minimize crowding because of COVID. But what we have also found is that it's reduced the chances of clients seeing each other and kind of minimize that potential embarrassment or fear. Next slide, please. So I started this presentation on a slide with many lines, and I'm going to end it with slide with one. And this is the number of teenage pregnancies in Puerto Princesa, city here in Palawan where we're operating, for the past 5 years. As you can see, the number of teenage pregnancies has dropped significantly, right? 1,500 in 2017 to under 500 in 2021, which is bucking the national trend. And I'm not saying that all of this is due to what Roots of Health has done, absolutely not. But what I can tell you is that outside of Puerto Princesa and the municipalities in Palawan, these numbers have not changed significantly. They dropped due to lockdowns, but that was really just because of that. We've seen that happen pretty much everywhere, I think. The next step is to work on the municipalities outside Puerto Princesa, which is a tad more difficult. So next slide, please. I know I said I was ending, but this is really my last slide. So here we've got two of our youth advocates doing a bit of a silly pose while conducting some HIV screening in a rural community. So we're going back to access. I was asked to give some recommendations, which I found quite difficult because I feel like, places are different, people are different, and so challenges and solutions will be different too. But what has worked consistently for us has been following this process. And number one, just listening to our stakeholders, and then working with them, figure out, to develop solutions that could potentially solve the challenges that we're seeing, and then, implementing it, but also giving it enough time to see whether it's going to succeed or fail. But at the same time, I feel like, if you see something that is not going to work because of an incorrect assumption or something else, don't be afraid to pull the plug. It's just as important to stop doing the things that don't work as it is to try the things and keep working, keep doing the things that do. And the other one is just to adjust and repeat the process until you find something that works. As Thomas Edison, the inventor of the light bulb, said, "I haven't failed. I've just found 10,000 ways that won't work." And I'm not suggesting that we fail on purpose, but just that we keep experimenting until we find what works for the communities that we serve. So these have been the things that have worked for us, and I hope that some of you find them helpful. Thank you very much.
Thank you very much, Marcos, for sharing your experiences. So, like what Marcos said, right? Develop solutions with the people that you're serving, and also give it time. Give it time. And if you think it's not working, pull the plug. It's okay. It's okay. So there you go. So, and I'm also seeing some of the answers to the questions earlier. Some said that how they have responded to the needs of those living in very rural areas. They said utilizing local resources or partnering with health schools who are serving underserved populations. Some strategic planning, they're doing it to ensure that it goes smoothly. So thank you once again, Marcus, for sharing your experience from Roots of
My
Health.
pleasure.
And now, if you have any questions for Marcos, please do type in the chat box. And later during our Q&A, we will be collating all these questions and we'll be asking it to our speakers. So before I introduce our next speaker, We once again have a question for you, our dear audience. The question is, in your family planning or reproductive health programs, what's one way you have provided disability friendly services? So, only one way. As you type your answers in the chat box, I'll be introducing now our next speaker, who is from the Blind Youth Association of Nepal. Established in 2012, Blind Youth Association Nepal is a national non government organization in Nepal, run by blind people and partially sighted youth. It is a rights based organization that works to ensure blind people, partially sighted people, and people with disabilities, or PWDs, enjoy an independent and dignified life in an inclusive society. Working across many areas, including awareness raising, policy, advocacy, and economic health and rights promotion of young people with disabilities and partially sighted people, it aims to improve the living standards of PWDs by increasing their access to disability inclusive education, health, economic, and other relevant services. Okay, so to share their experiences in responding to family planning or reproductive health needs of people with disabilities, let us welcome the founder and general secretary of Blind Youth Association Nepal, Ram Chandre Gaire. Ram?
Hello. Hi, Gaio. Thank you very much for this nice introduction. Hello, everyone. It's been a wonderful to be here, and let me share what we have been doing and who we are. So, Emily, can we go to the first slide? As we say, we are Blind Youth Association Nepal. We have been doing various SR, HR, and FP promotional activities targeting to the persons with disability, particular focus with the adolescents and youth. Next slide, please. Let me start my presentation with some of the real case stories. In the picture, you can see some blind women touching pills. So this woman is first time attending our training program, where we have invited different youth with different disability category. And when we were discussing about this, she was surprised when she for the first time touched the pills. And the first question on her mind was, oh, it looks the same. From which side to start? If you are not a blind person, maybe you cannot visualize this. But let me share the live example from Samjana's surprise. The lady shown in the picture, she is a blind woman who cannot see the arrow or the icons from which direction to follow while taking pills, either which one is the iron tablet or which one is the pills. So taking this surprise, we can see how our contraceptives or the family planning products are designed keeping without blind people in mind. Similarly, in our training program, next, I would like to go to the next slide. We had another participant who is a young woman of age 28. She is Kopila from Kathmandu, Nepal, and she is 28 years old, hard of hearing woman. In Nepal, it is very surprised if somebody talks loudly about sexuality and contraceptives. Neither in a school or in any program, people usually don't talk loudly about sex or physical changes or contraceptives or sexual relations. As my colleague Marcos mentioned, nobody talks about very loudly about condom. If somebody talks, it feels kind of shame. So during her school, she has never learned about these kind of things. Neither her teachers, neither her colleagues or parents openly talk about these kind of things, because usually people talk very in a whispering or in a very silent way. And she cannot hear any information unless people talk very loudly and very slowly. So this was in her 28 years lifetime. It was her first time experience talking about these kind of things. So it was a very first time that she was getting information about contraceptives and SRHR. Let me share you the next slide where you will be able to see a group of mothers with their children with autism and intellectual disabilities. As we know, the sexual desire and the needs are biological needs. Despite of different disability, these needs are there. But these mothers don't know how to understand their children's sexual needs or how to respond when they are reacting about these kind of things. That's why they were attending our programs with the intention to seek the solutions. So because of these case study, we can see that there are a number of problems faced by the people with different types of disability. And that leads to touch on the issue of intersectionality, which my next slide I'm going to talk now. So when we talk about intersectionality, as Marco mentioned, different contexts, different background gives different understanding on the intersectionality, which Gaio has beautifully presented in an opening statement as well. So in our context, when we say intersectionality, the inclusion of the cross disability, like a people from different disability category, is itself a great example of intersectionality. Not only that, the poverty, the gender, physical remoteness, and the caste, different, the so-called Dalit or from the marginalized or the physical remoteness, all these, and lack of awareness, lack of education, all these comes when it is associated with the different disability category. The needs and access of the SRHR for them is further worsening. And language is another challenge when it comes to the intersectionality, because in Nepal, when we initiated the SRHR related interventions targeting for the people with different disability, we encountered several challenges. We had a participant from the deaf community where they do not have any specific sign to communicate about the contraceptives. They know about the sign on the condoms, but nothing else. So when we have to offer the training to them, it's very challenging. Even if we use the sign language interpreters, there has not been any sign developed to communicate these kind of things. And honestly speaking, the word intersectionality does not translate in Nepali sign language because no one has developed this kind of things. And when it comes to the LGBTIQ+, these kind of words, this kind of concept, it is very, very challenging to communicate with the deaf people. So the language barrier is also a major challenge. And the same thing applies because even if we, sometimes the general mindset of the people is, okay, for the blind, Braille or the audio, for the deaf people, sign language. But there are other type of people who may have their intellectual disability, for which they may require different forms of content, which we call easy reading text. The text with very few sentences, very short sentences in a plain language, the way our colleague Marco has beautifully made the picture form. So this kind of easy language is also, we understand, as a part of intersectionality. And one of the major challenges when it comes to the intersectionality is disclosure of the intersectionality of the disability population itself is a very challenge. If I am a blind, do I recognize as a blind person? If I'm a Dalit, do I recognize also Dalit plus blind person? If I'm a woman, poor, uneducated, Dalit, and HIV affected, how do I expose my intersectionality? Do I perceive really in an acceptance way from the community? Either I might be over pity or I might be completely left out. So because of these things, sometimes the disclosure of the intersectionality within the disability is also challenges. Yes, there are several challenges, long way to go, but in disability, in our advocacy work, sometimes we say we make the road by walking. So what is that road and how did we walk? Let me share with you what worked well to my next slide. When we design our interventions, the first thing we always try to incorporate is the cross-sectionality, representation of the different disability community. In the introduction, as Gayo introduced us, we, being a Blind Youth Association Nepal, we not only focus our interventions to the blind and partially sighted people because there is an equal need for other disability community who do not speak, who do not understand, who do not think properly, or who have a mobility restriction. So we realize that we need to be strong. That's why we need to include this intersectionality. And another issue is developing a peer group or the peer educator within the similar disability category. Because during our interventions, we form a peer educators of the disability youth group. So even after various interventions are over, these peer educators are now very openly discussing about these things. Another thing that something we usually do not apply is one-to-one learning or teaching approach. There are so many blind people or people with intellectual disability who need additional attention or additional time or care to communicate the similar things. Just for the blind people, if you want to feel them anything, you have to let them touch. Or if a woman like Kopila who has a hard of hearing, she may require additional time to communicate because she do not understand if somebody speaks fast. So that's why certain skills are required. That's why we develop the one-to-one learning program. Another, our successful outcome is working in a collaboration with the stakeholder and the right holders. In one way, we found, despite of high unmet need, there is a low demand in the disability population because they don't think that the service centers or these things are not for us. That's why it is very important to build the capacity of the persons with different disability to make them able to claim that the SRHR is their rights. It is not the matter of shame, it is their dignity. They should be able to claim their things. To make that realization, we need to focus on the capacity intervention, which we are doing. Small in scale as per our organization's size, but really worked well. On the other hand, our stakeholders, government, CSOs, or the donors, they have been trying to include the disability population, but the capacity is something very much gap. That's why we have been conducting various awareness and sensitization program targeting to the government people to sensitize on our issues. Because sometimes everybody want to say that, oh, we want to be disability inclusive right now. What is lacking is, but how? So working with the disability population and the government, we are trying to bridge the gap and address that how part. So with all those things, working with them, finally, on the next slide, we would like to offer some of our recommendations through the next slide that we strongly urge. In some places it may be contextual, but this is what we would like to offer in the form of recommendation. The first thing is there has been very less discourse, study, and the research on disability. So if we see the global literature, we see very less documentations on disability and SRHR. Similarly, we find very few people who can confidently deliver about these contents, very honestly. That's why it's very important to have a disability specific discourse like the one we are doing it. Further research and studies should be there to have disability specific data plus other information. And when we have these kind of data, then only it will offer us some ways on how to design and plan the intervention, for which it is very important to partner with organization of persons with disability. Many donors and organizations may not found that the organization of persons with disability might not be in a right position to partner at the moment. That's why it is very important to design the segmented program to support the capacity of the organization of persons with disability so that they can be able to offer what they want. And on the other hand, it's very important. My final recommendation would be all government stakeholders, donors, and partners of the civil society organization, they should do the accessibility auditing in their policy, programs, budgeting, and service delivery and overall intervention. Just saying that we would like to be disability inclusive may not justify what we want to deliver. That's why it's very important to have certain checklists or certain indicators that will reflect in our policy. From this lens, we are disability inclusive in our policy, in our program, and in our budget. So when we do these kind of things, in my next slide, as I confidently say always, if we could do these things, stakeholders are there, we right holders are here, we can make the opportunity to make the rights real. So let's work together. Let's create opportunity to make the right real. Thank you, and I'll be more than happy to respond to your question, if any. Gayo, over to you.
Thank you very much, Ram, for sharing your experiences. So Ram from Blind Youth Association Nepal, like what he said, I learned a lot also. There are various disabilities to consider, right? And for us, sometimes we think, oh, only those who are blind, only those who are deaf. But like what Ram said, oh, there are also the intellectual disabilities that we have to consider. So there you go. Thank you, Ram, for that very nice presentation. We actually have another third speaker, but unfortunately, she's having connection issues. So she won't be able to join us right now. So we'll go next to our question and answer. So before we go to the Q&A, thank you once again to all our speakers, Marcos and Ram, for sharing your experiences. So now we will be opening the webinar for the questions. So first is for Marcos. Marcos, someone requested if you could please put the link to the tool that you have mentioned in your presentation. So, and you can also share it after this session. We can send it also through the email after for all those who participated today. But Marcos can also share it right now in the chat box. And for Ram, there's a question from Tara. Do you use a specific inclusion audit for organizations to use? So that's the question. Do you use a specific inclusion audit for organizations to use, Ram? Oh, you are on mute, Ram?
Yes, okay.
There.
Thank you, Tara, for this question. Yes, generally this one set standards may not apply to the different organization, but yes, we have developed some national tools that we have been using within our organization and different branches office. And if somebody wish to use that, we can definitely share that to you, Tara. And but unfortunately, that is so far in Nepali language. As we say, we want to make it more accessible. But we can share you some of the other tools that other OPDs are using that might be available in English. Please share your contact info. My director is here to take the notes, and he will be forwarding it to you. And if that is required for any other participant, we'll be more than happy to share it. Please share your contacts. Thank you.
All right. Thank you, Ram. So Marcos already shared the link in the chat box. Marcos, would you want to share a bit about this tool that you have mentioned earlier in your presentation?
Sure. I mean, it's great if you're working on logic models and trying to see how things relate to each other. In the past, I've always just used Excel, and it's a pain in the butt because you spend half of your time cutting and pasting and rearranging things. This just does it for you automatically. You just put in arrows where you want it to go, and if you delete things, it just rearranges. It's pretty fantastic. Yeah, so I was gonna say I was reading some of the comments, and I noticed that some people were talking about schools and peer educators and things like that. We do work on those things. We've done a lot of work in schools, and yes, we can see that there's knowledge change, but at the moment we're not actually seeing that translates to reduction in teen pregnancy or increase of contraceptive uptake. So that's why I didn't include that as in like what actually works, because we just don't have the evidence of that right now. And yes, it is very important. And something that we've really noticed here in the Philippines is, and I referred to this earlier as well, is that the teen pregnancy rate across the country has dropped, or it dropped in the previous year. And when you think about it, for young people, the thing that changed the most for them was that they weren't in school anymore, right? So it was just kind of a little bit of an aha moment when we started looking at that data and thinking about what the possible causes of that could be. Because here in the Philippines, they've only just instituted comprehensive sex education, and it's not being implemented really properly yet. And yeah, the teachers like to believe that it's somebody else's problem. The parents should talk to the students, the nurses should talk to the students. But kind of one way we're looking at trying to flip that with the teachers when we do more teacher trainings is, to point to this data, to say, okay, well, schools are a kind of meeting point for a lot of young people, and we can see kind of what's happening as a result of that. With peer educators, we found that maybe it's different for different groups, but we found that once a peer educators network is kind of saturated, then that's that. It is what it is. So what we've worked on doing is finding other more active things that the peer educators can do, whether it's distributing condoms, being an assistant in the clinic, making follow-up calls, doing HIV screenings, all helping out on the media side. We've really found that young people want more like hands-on active things to do rather than just passing on information, which can be quite difficult for them. So yeah, thank you.
In relation to that, Marcos, like what you're sharing. So, what have you found aside from what you shared that did not work or would not work in terms of providing inclusive family planning or reproductive health information and services?
So something that we're really working on is health workers. The biggest issue that we're seeing with regards to young people is that adults don't want to deal with it, right? They don't want to acknowledge the reality, right? Maybe it's kind of like an issue of climate change. But adults are very uncomfortable with young people being sexual beings, right? So as soon as a young person here comes to their parents saying, "Oh, I have a crush on this boy," the parents often totally overreact, like, "No, you cannot have a boyfriend. Don't even think about it. Sex is bad." And it's like, I'm not even talking about sex.
So the
The
adults,
health,
the adults are the problems.
the adults are absolutely the problems. I was speaking to a social worker the other day, and I said, "Oh, what do you do if a young person comes to you and they say, like, I want to get some sort of service because I'm having sex. Will you talk to that young person? Will you counsel them?" And the social worker said no. And I was floored. I was like, okay, I understand this is like normal for healthcare workers. And I asked her why, and she said, "Well, I don't want to deal with angry parents. If I give this young person some advice and then later this young person tells their parent what I said, then the parents are going to come and get angry with me." And I feel like that is the crux of the issue. Like, whether you're talking to a health worker, a teacher, or a social worker, their main concern is how it's going to impact them. They're going to have awkward conversations with parents. Like, they're not thinking about what is best for the young person. They're really just thinking about what is best for themselves. So to go back to, I guess, what you asked, we're trying to figure out what the best way is to engage them on these things, because we've done a lot of trainings with these stakeholder groups, and there's not that much uptake, right? If we're going to be honest, like 10-20% behavior change, whether you're talking about parents or healthcare workers, teachers or healthcare workers, like actually delivering sex ed or actually providing youth-friendly services. So yeah, it's like, how do we actually move that needle? Because I think it's more about behavior change and focusing on the motivation side than just like the information side of it. So we're now piloting new models for that, but just if you want to leapfrog or if you have any information, share, please.
Thanks, Marcos. And probably
Sure.
this last questions, I know you have more questions to ask, but this one for Ram. What would you say, okay, to organizations that have realized that they are not successful in being inclusive when it comes to providing family planning or reproductive health services? Any advice to these organizations who have realized they are not successful yet in being inclusive when it comes to providing family planning and reproductive health services?
I think thank you for the question. That's a really great question. And I think this is already a very good beginning, that realizing that we are not success to become a disability inclusive. That is the right milestone to begin with. So I would recommend to reflect, go to a little bit flashback, why we are not success. Is it we are not success because our planning was not inclusive, or our interventions was not inclusive, or we were thinking intentionally but did not plan accordingly? Did we had adequate resources to become a disability inclusive, or have we prepared? Did we train our providers, or the leadership are really committed with, as I said, policy, program, and budget? I think this need to be really review and check all those things, that components. And also, if that is just everything is there, but if it is just the issue of capacity gap, then I would recommend to consult with the organization of persons with disability, because they will offer you the right way or the right path, because they are the beneficiary, so they know what size fit for them. If I can say that much, I think that will respond to the question. Thank you.
All right. Thank you, Ram. So really, it's important to work with those people, plan with them to those who are affected by the issue and the concern. So, thank you once again to our speakers for sharing their experiences on expanding inclusion for Indigenous youth population and people with disabilities. And of course, thank you to all our audience for being with us up to this time and actively interacting through questions and comments. But before we end, next slide, please. We would like to share with you that we have developed a collection of resources on expanding inclusive family planning and reproductive health services in Asia and on FP Insight. So FP Insight is actually a new tool to help you discover and bring together all your favorite online FPRH resources in one place. So here's an example of the FP Insight collection of various resources on our topic for today, and you can explore our collection through that URL. And once you have created your own account, it's very easy. You have access to all these resources on family planning and reproductive health. And if you want to, you can follow the collection, and then immediately you will receive updates when we add something new, or when you add when and you can save any resources of interest to your own FP Insight. So next slide, please. We'll be sharing this presentation to those who have attended in this webinar. So you can just click on the link and check out FP Insight. There's a tutorial. It's very easy on how to have an FP Insight account. And if you are interested to be co-collaborators in this collection, please do just send me an email at gayoso.grace@knowledgesuccess.org. And of course, to be updated on what's trending on family planning and reproductive health and on learning opportunities related also to knowledge management, please do subscribe to our website at www.knowledgesuccess.org. Thank you again to Ram and Marcos, our speakers, and to our audience for today. Thank you, everyone, and have a good day.